see that.
Oh, yeah.
I'm
like really excited.
All the powerful you have to we had a program.
That's what I did. Shows me
Yeah, that was the DNS. I think I did. No, I had me down. The Army did something like
So the whole panic Mario working now completely disappeared.
Oh, that's not good. Oh, it could be good.
I know the one light is good, but then the other light is. That's what I'm thinking.
Good morning. Hi there. Great. Thank you all for coming out today. And I was joking, normally when there's a conference and I see that registration is 8 to 8:45, I roll up like 8:40. I think that's probably that's a personal shortcoming. But thank you all for being early and for showing up. I'm sorry that nobody dressed up on Halloween, but we welcome you anyway. So my name is Craig Behm. I am the program director here in Maryland for CRISP. I'd also like to welcome, we have Ryan Bramble who's speaking next, who is the executive director for DC, and we have some folks from West Virginia. So it's a true regional collaborative, and it means a lot that so many people are here. If you know anything about CRISP, we tend to work very incrementally. So this is our second user conference. We've been around for 10 years. We've done 2 user conferences. We started slow. Last year, I believe we had 150 people. And that was a big stretch for us. We thought, there's no chance this many people possibly want to come out and talk about IT, which I guess is a misnomer for 2 reasons. One, we're not really talking about IT that much as we're a technology firm. But also, I don't think you're coming out to talk about CRISP, luckily. And so this year we thought, well, we'll be incremental. Maybe we'll do 200 people. we could maybe have a stretch and do 250 because we didn't want to go crazy. And so we opened up registration, and everyone registered the first day, and we capped at 250. And so we said, let's do 300. We don't want to do more than that. And shockingly, I think we're going to have 400 people here today, which, yeah, thank you. So on the one hand, it's really positive for us. It means a lot to all the staff and to, I'm sure, our leadership that you're all here. And I think it says something very positive about what CRISP has been doing for the past decade in the state. I actually, though, think it says more about all of you and the health system itself. CRISP is, in many ways, just a series of pipes pushing data back and forth. And it's probably more important that we have healthcare leaders and providers and patient advocates and care managers that want to come together and share ideas and talk to each other and partner and have best practices. And so I'm really proud that CRISP can be a conduit for that. But I also know that you're here more for each other than for us. And that's probably very appropriate and a very good thing. So thank you. Thank you for coming. I have a couple housekeeping items to share before we welcome our first speaker. So first, hopefully you saw on the way in, we have a Genius Bar. I hope that's not copyrighted. We have the CRISP customer care team who, if you ever call the support line or email support, these are the folks who respond quickly and unlock passwords and do all sorts of other great stuff. So they're here to go through demos of the systems. If you have questions about details or your level of access or credentials, these are the folks that can solve problems in real time and hopefully start putting faces with names. Because I think probably a lot of you talk to a lot of them pretty frequently, and that's a good thing. They will have raffle tickets, along with a lot of our partners in the hallway. We have raffle tickets you can enter a bunch of times, and we are giving away, I believe, 5 CRISP-themed Yeti mugs, which, yeah, these are nice, especially as it gets cold. They keep everything hot all day. This is the first year we're doing continuing medical education for physicians. So if we have physicians here and you want CME credit, it's just like it always is. On the folder on your table, you'll have the survey and all the information. So please be sure to fill that out. I'm actually interested to see kind of how that goes. We want to get as many actual providers here as possible. Again, caring a lot about end user feedback, and that's one way we think we can get people here. But so hopefully that helps. We are also live streaming this event. So Maryland's not a huge state, but it's big enough that we know it's inconvenient to drive maybe from Garrett County or from Salisbury, although I think I've seen people from both places. So we are live streaming. So everyone in this room, if you say something in front of the mic or you walk in front of the camera, you will be live. So be mindful of that. And again, thank you for everybody who's tuned in. And then finally, kind of be on the lookout for CRISP staff, not just the Genius Bar, but in general. We have a lot of people here. Very selfishly, the reason we do this is because we want to add value to all of you. Ultimately, the point of CRISP tools is to enhance health and wellness so that when you all work with your patients and with each other, you're making better clinical decisions, there's more transparency, you can test interventions and see if they're working. So please share feedback with us as the day goes. We intend, both today but then in the future, we will be very accessible. So don't be afraid to reach out, ask questions. And then also, we hope you all talk to each other a lot. Last year, one of the big pieces of feedback was the presentations were nice, the people were nice, the venue was fine, but we really wanted more time to network. You all have a lot of really good ideas, and I think we have a lot of best practices as a leader in the nation, both in our payment model and in the way we deliver healthcare. So please take time to share with each other. Again, CRISP, we're the pipes, we're the conduit, we're pushing data, but it's really up to all of you to work with each other to keep making patient care better. So again, thank you very much for coming. Thank you for being willing to do that. Thank you in advance for your feedback. And I would like to welcome up Ryan Bramble. I mentioned that Ryan is the Executive Director of CRISP in DC. where he's working directly with the Department of Healthcare Finance to do public health projects and working directly with the providers down there. Ryan has been with CRISP since the very beginning, and so he was responsible for the technology and making sure things worked in the past. Now, in addition to DC, he is the Senior Director of Products. And so he's the one, when I'm out in the world and people say, man, it'd be really nice if CRISP could do such and such. You know, I would love a longitudinal view of my patient interactions. I text Ryan, and Ryan normally either says, yes, we're already working on it, or yes, but not quite yet. And so he's going to tell us more about the stuff that CRISP is currently working on. So Ryan, come on up.
All right, hello everybody. It's nice that Craig and I have a relationship where I can lie to him frequently about and texting's a wonderful thing that's been added to sort of the work environment. So yeah, I'm in charge of our products, and that's what I'm going to talk about here today. I think, as Craig mentioned, I've been with CRISP since it started, so it's been about 10 years. There were 3 or 4 of us squatting in a corner of an Erickson Retirement Communities corporate office at the beginning. And it is incredible to see all of you here and what you all have helped us build together. And the engagement from the community is really empowering, and the staff really appreciates it. You'll see a lot of that today, but really do appreciate your engagement on this. And as I'll say, at the end of my presentation, our development pipeline, our product pipeline is really shaped by what you guys need. We don't pretend to know everything. We're not Apple. We're not going to tell you what you should like. You're going to really tell us what you need, and that's really how we sort of build out the stack in an incremental way. So there's a lot of stuff CRISP is doing. I'm going to focus on two areas in our core services group. So we like to think that CRISP offers 5 core services: point of care services, care coordination, population health, public health, and more recently, program administration. Most everybody in the room is probably using CRISP for at the point of care or for care coordination type purposes. So I'm going to focus on the new products and enhancements to existing products that are coming over the next year in those areas. We try not to plan too far past a year because things change so quickly. EMRs, electronic medical records, adopt new technologies and what they'll support sort of on their pace. So we try not to think too far ahead, but I am going to run through some things that you should or hopefully find interesting, and definitely able to take your feedback outside of the room. If you want to see demos of some of these things, you can go to the Genius Bar. They're going to be demoing a lot of the existing products. This presentation does assume that you guys are a little bit familiar with some of the products, but if that's not true for some of you, please seek us out after and show things at the and we can show you some of the things at the Genius Bar. All right, so I'm going to focus on the point of care first. And I just want to keep track of time here. All right. Okay, so there are really I like to group the point of care applications into 2 buckets. There's the unified landing page, which is essentially the way, via the internet, you go out to a web browser and you can interact with the CRISP tools. And then there's what we call CRISP in the workflow, which is us making an effort to get CRISP data into the systems you use every day and not have to go out to a different portal to look up and interact with CRISP. More and more, and you'll see a theme here, we want to be providing data in the screens you're used to seeing. Maybe even get to the point in a few years where it's not even clear it's coming from CRISP. It's just part of the medical record that CRISP is a part of, that you're hooked into. So we know how inconvenient it is to need another password, need to do another search, need a password manager to manage all your passwords. We don't like doing that stuff too with our banks and our credit card companies, whoever we deal with. So really we want to be driving this information into your workflow. So you'll see that theme here. That said, we recognize many users need access via the web, don't have either the sophisticated EHR, don't want to spend the money with the EHR. The EHR can be expensive when they're trying to upgrade you into things. So we are committed to building out the best web-based tools as well. And so I'm going to run through some of those things. I'm going to start with the query portal. So the query portal is really the oldest school tool we've had. We've probably been running the query portal probably like 7 years now. And the query portal is where you go and you look up lab results, radiology reports, transcribed documents. It's changed a couple of times over the past 7 years. It's about to change again. The user interface is going to change again. We're looking to make it a little bit of a better experience. What we hear when we talk to you all is that it's great to have access to all of this clinical data. It's really hard to find what I need. Hunting through 30 lab results, or for really sick patients, hundreds of lab results is not doable. So with that in mind, we're going to make some improvements over the next year to the query portal. The biggest thing, which I kind of referenced there, is that you're going to be able to search through the results. So you'll have a lab viewer. If you're looking for a particular type of lab, you'll be able to type in something a la Google, and it will sort of narrow the list down. Same for reports, same for transcribed documents. Pretty basic, something that probably should exist already, but it's something we're building in on top of that. The other big thing we hear is data quality. So not so much quality as much as consistency. So we recognize that as CRISP has built itself up over the last 10 years, things that were important 10 years ago, weren't important 10 years ago, are more important today. So maybe in the past it was just important that we got that discharge summary from Holy Cross into the system. Now it's important that we have coded results in the system that you can track over time, that can be used to make clinical decisions that you guys are making. And it's not good enough just to have the data in there. And what we hear is that you might see discharge summaries from one hospital, but you don't see them from another. Or you might see lab results from one hospital, but you don't see them from another. So there is a team that's been built to really go back out, talk to everybody, and try to get consistency across all the data sources so that when you go into CRISP, you will see a discharge summary if you're looking for a discharge summary. So that's also happening. Image exchange, I don't know how many of you have experienced the image exchange through the query portal. Something like 30 of the hospitals are participating in the image exchange. We want to continue to roll that out further so that you can view diagnostic quality images directly within the query portal when looking at a RAD report. We also are going to try and build some indicators, and I'll talk about this later, in your EHR that there might be images available to indicate to go out to CRISP to look through them. And the last thing I like to put on here is that as we are incremental in our rollout of products, we recognize that sort of what we call the minimally viable product, the MVP, the product that can go to market, but maybe isn't as perfect as we want it to be, needs to be improved over time. So we've implemented in our process what we call paying down the technical debt. Maybe a little shortcut we took to make sure something was working, but needs to be you need to go back and clean it up later. So this is when you're using your phone and you notice there's some bugs. You know, Apple's doing the same thing, Google's doing the same thing. It's important though, from a CRISP perspective, that we're able to go back and improve the shortcuts or the bugs that were taken as part of the process. So it's really important that as you all are experiencing errors or things that don't seem right, that they get reported to us. I know that's kind of a pain to do, but it is really helpful when we get the feedback that when I log out, it doesn't always log out, or maybe when I hit search, it doesn't always work the first time. Those types of little bugs are important for us to get back. So we have set up a structure to basically pay down those issues as we move through the year. I'm sure many of you use the PDMP, Prescription Drug Monitoring Program. We're doing two things in the near term on that. We are adding access to compliance reports. This will allow prescribers to look at compliance to the PDMP, allow administrators to look at compliance to the PDMP. We're also adding a tool that allows you to self-audit your prescriptions that are dispensed. So you can see what has been dispensed through the PDMP for which you as a prescriber have been sort of have prescribed, and this might help you catch fraud or at least understand the prescribing habits. One other thing we're doing is increasing our out-of-state connectivity. So we have the contiguous states PDMPs connected into the Maryland PDMP. We're going to try and roll that out even more broadly, knowing that folks who seek out opioids often go to great lengths to get them. So it's important that we have more than just the contiguous states in the PDMP. So those are our two core applications and some of the improvements happening there. I want to talk about the patient care snapshot. How many of you have seen or used the patient care snapshot? It's relatively new. Okay, fair number of you. So the patient care snapshot is a tool that we developed that essentially goes on the understanding of, yeah, there's a lot of clinical information in CRISP. What is critical for me to see sort of at a glance? And if I want to dive deeper, I can. So we deployed the patient care snapshot first in DC about 6 months ago, and more recently in Maryland and West Virginia. And it essentially, and I know it's hard to see here, but essentially pulls up key facts about a patient as you query. So you query for the patient, and you could find you get a timeline, which is on the right there, the recent encounters. You get the list of the clinical care summaries that come from some of the EHRs. You get the care alerts, which are those 1 or 2 sentences that a provider has written that they want the next provider to see, no matter what. So you get the care alerts in there as well, and we're working to add more features to that. And the reason I highlight Snapshot is it's actually pretty critical to some of the things that we're going to be doing over the next year in making it more customizable. So if you look at the current features right now, it's recent encounters, summaries of care, the care team, which is also something that folks have told us is valuable information, especially the ED, to know that a patient's in care management somewhere else, who the care manager is, who the PCP is. That's all available today in Snapshot. We also are able to tailor Snapshot to certain regions. So as I mentioned, in Maryland, the care alerts is a big thing. In DC, we actually have Medicaid claims inside Snapshot, and we're working here in the other regions to get access to more administrative data, especially as the processing time for claims data improves. It's proven valuable to get claims data in at the point of care, because this will cover a lot of those office visits that there might not be an integration for. We're seeing big success with that in DC. And then in West Virginia, for those of you who are here from West Virginia, we're working with an organization that has a NARCS care score for their opioid. They call it a NARCS care score. It's essentially a likelihood of opioid abuse, but in their to support their prescription drug initiatives in West Virginia. So this is what's there now, and there's a whole bunch of new stuff coming to the snapshot. And so one big thing is going to be the resource directory. So CRISP, it's one thing to tell you all that a patient is in a care management program, and it's another thing to know what that care management program actually does and what it offers. So we're working with folks that are telling us about those care management engagements and asking what those programs do, what resources are available in those programs for patients. So we have a resource directory we're building that we're going to link into this, so that if you see someone's in care management, you can see what that actually means. And the resource directory also will be available to look up potential programs to enroll someone in, resources that are available in the community. We also are working, right now we're in a pilot with support of the Maryland Healthcare Commission and the University of Maryland Medical System to pull medication lists out of clinical summaries. So this would be sort of the medications that are prescribed at discharge. So not just the opioids now, we're talking about anything that might be prescribed. We want to be able to extract that data and put it into a widget in the snapshot, essentially, in a way that's meaningful. So that is harder than it sounds, so we're being very incremental about that, and hopefully we have some good results from that pilot in the next 3 or 4 months, and we can look to expand that. The two things which are in red, it's hard to see here, we want to start to build user interfaces for folks based on what they do. So if you're a cardiologist, you might not care about 40% of the stuff in CRISP, but you really do care about cardiac caths, and you really do care about the lab tests that indicate if a heart attack may have occurred. So we are in the process of building 2 customized snapshots for your role. So if you're a cardiologist, or if you are someone who is part of a maternal health team, a labor and delivery team, or an OB, we're building snapshots that you'd be able to see based on who you are. And that is through some good work from our medical team. Dr. Desai leads that, and he's convened some subcommittees that are talking about what should be in those different snapshots. And we want to do a lot more of that. It's somewhat painful to try and hunt for the right thing, and if you're a maternal health provider, you may only care about 3 or 4 things. So getting that stuff sort of pulled to the front is something we're doing. And then also, giving folks who have the CRISP button, which I'll talk about later, the single sign-on button, if you're in your EMR, to push the CRISP button and CRISP pops up, exposing Snapshot to you all. Right now, it's just the web-based access that has that, but we're working over the next, this is really more of a late 2018 goal, to get folks access to both CRISP apps through the CRISP button, and then any future application CRISP builds would also be available through the single sign-on button. So those are the things that are happening with Snapshot. I mentioned some of the details about what we're putting into those particular snapshots of cardiology, maternal health. Of course, happy to take more input on this stuff, so if you have ideas about what you all would want to see, please stop one of us in the back and let us know what you'd want to see. If there's a snapshot version you'd want to see outside of these two groups, let us know. We also have something called the Alert Center, which right now is only for the PDMP users. It indicates a potential overdose event from some of the ADT feeds. We're expanding that Alert Center into Snapshot so that we can alert you for things that are reported to us that are more of a public health in nature. So overdoses, but also Zika infections, CRE bacteria that a patient might be resistant to the meds for, tuberculosis, anything that comes from public health. We're actually going to flag that as you look up the patient in the snapshot. A little bar is going to come down, just like on your phone, with an alert that says there's an alert, this patient may have had an overdose event at this hospital. You may want to contact the hospital, something along those lines. So while that exists in the PDMP world today, we're going to be moving some of the other public health things forward into Snapshot. So these are the improvements that are coming to the web-based tools. I want to talk about the point of care through automated tools, which is sort of all the rage now. There's a lot of meaningful use money going out. There's a lot of grant money going out to try and get HIE data, healthcare data, more embedded in what you do and how you access your patient's medical records. There's also a lot of money going around for healthcare organizations to, and this is in meaningful use specifically, create what are called APIs so that patients in the meaningful use world can get access to their data directly from an EHR. But API structures also allow data to be communicated more easily between organizations, including CRISP. So I'm going to get just a little technical here and try to explain what we're doing around APIs and then more practically what it actually means for you all. So I do want to just, first things first, a primer, what am I talking about? I'm sure you guys hear APIs around the community now. It's sort of a buzzword. Pretty much everything you do on your phone interacts with something via an API. An API stands for an application program interface. It is really just a thing where you can put data and get something back, or I can ask for data. So the example I like to use is if you put up Google Maps on your phone, you type in the place you're going, what you're doing is you're posting your address to Google through an API, and then Google's giving you directions. It's really a slimmed down way of communicating. Back in the old days, and when I say old days in IT, I mean like 3 months ago, there were enormous packages of information that were being exchanged through methods that were slow. And so it was hard to get an entire CCD, for instance. I'm sure some of you experienced the pain of querying for an entire CCD of a patient's entire longitudinal record through sort of an older school API integration. Those things are slow. APIs are not slow. You know how fast it is to do stuff on your phone. So the same concepts are being applied to healthcare. Healthcare, as usual in the IT world, is late to the party, but we are getting there, and CRISP is engaged in a lot of this stuff. Another example, I'm bolding here, posts. You post your address to Google, you get directions. You can also get stuff. So you have Twitter. Get me the latest tweets, and it gives you the tweets. And so the post and get are really the only two things you need to know about APIs. It's a thing where you post and a thing where you get. So how is CRISP using this information? So we have built, really in the last 6 months or a year, mostly, a suite of APIs that allow EHRs to get data from CRISP automatically. We're not doing so much on the post to CRISP at the moment through APIs. We're doing a lot of gets. So this means when you're in your EHR, and let's say you're in Epic, and you're integrated in the PDMP, you can, without doing anything, get data from CRISP. So some of you may have seen, I'll flip back and forth here, but seen this type of screenshot before, which comes from MedStar. And this is Cerner, this is their EHR, and it's hard to see, but there's a list of fake medications for this purpose, but there's a list of medications in that little, what they call an M page, but that little box in Cerner. This is happening automatically. I open the chart, it sends out a request to CRISP, what meds do you have for this patient? CRISP responds, and in under a second, the data shows up. And all these interactions are super fast compared to the old interactions. Our team starts to freak out if these alerts, start to get near 1 second in their response time. They really should be 200 milliseconds, really, in a lot of these responses. So we started this effort really to support the PDMP construct. We knew that in order to support the state and their mandate, providers are going to need to be able to get to this information, especially in the large hospitals. They're seeing tons of patients. It's not really great to go out to a portal all the time and look that stuff up. So we built these APIs in support of that. But we're doing a lot more than PDMP through the APIs. You're able to see the care alerts, which I mentioned earlier, through APIs. You're able to see the care team information. You're able to see the recent encounters. You're able to see the overdose notifications. So all of this info is available to your EHR if they want to connect to CRISP's APIs, which is a relatively simple thing to do. It's not like back in the day trying to set up a new HL7 interface. You need to get a virtual private network established. You need to get the two network admins on the phone to talk to each other and exchange keys and all of that. This has really been made a lot more simple from with the enhancements that are happening with APIs. And so those are the existing suite of APIs. So this is where we started. We wanted to be incremental in this approach, but we have certainly gotten a lot of feedback. We're seeing unbelievable utilization of these things. While someone may query the CRISP portal manually, we're about 90,000 to 100,000 times a week manual queries. These are being accessed along the lines of 200,000 times a day, where the PDMP information is being fed back to CRISP. So a lot of it are fed back bidirectional exchange. So we see more and more of this. I think our focus this year is to get it used better, make sure it's being used. The CRISP team wants to not just throw data at you. We want it to be used well. So if there's anything we can do to sit with your providers and understand their workflows and all of that stuff, we want to do it. We want to make sure that the data is useful and powerful for what you all are doing in your day-to-day jobs. So we are not in this for the sake of counting things. We want to make sure it's being used appropriately. So there are a few things that are coming to the API suite that are new. We're quickly working through. We have a software development team that is, if you've heard the term agile, sort of a project management methodology. They follow it to a T. In one of the later sessions, we'll be talking a little bit about this work in more detail. Mike Banfield, who runs that software development team, can talk to you all about agile if you want. It's a little boring for those of you who are not into project management stuff, but it actually does make a difference as far as turning things through. So what's next on these APIs? So we're working to get the clinical data into the APIs so that lab data, radiology data, transcribed data would be available to you in your EHR. We work with your EMR vendor to decide how they want to integrate it. We don't want to recreate the portal in your EMR necessarily, but we want to make it easier to get to, that information easier to get to, easier to find depending on what your job is inside your organization. We're also adding images, so we're starting to wade into a little bit of what's called best practice advisory, sort of like clinical decision support, where we want to let you know that there's an image in CRISP as you're going through your process of potentially ordering an image. It might prompt you to go out and review that image that you might not know exists. Maybe they were at the hospital and they had an image done, and you're about to send them out to American Radiology or back to the hospital for an image. And certainly all of the organizations are incentivized to reduce the amount of scanning that's going on. And so we want to be able to support the fact that there are images out there and that they should be reviewed in advance of potentially ordering an image. And that's not just for images, that's also for prescribing, right? So why prescribe something if someone already has a bottle of it already? So these are all happening through things called best practice advisories and clinical decision support tools. You'll hear the term sometimes CDS hooks. It's essentially a way to interrupt your workflow with an urgent message about something that someone else knows. So the example here is we want to make sure you see there's a previous dispense before prescribing. And that is something I saw a screenshot the other day working in an EMR in a very test beta mode. So this is probably later in the year next year, but it is something we're working on. I'm going to spend no time at all talking about FHIR or FHIR, but if you like to read healthcare IT blogs, this is all you'll hear about for the rest of your life. It is essentially a standard to communicate APIs, communicate data over APIs that is healthcare related, and it is it's taking shape. It really is being used. Really the first practical use of that standard was the health app on your iPhone. If you have the health app on your iPhone, it's actually what's called a FHIR app, and it can integrate with the FHIR services, the FHIR APIs at the hospitals. And that's what allows you to download your records onto your iPhone if you're working with an organization that does that. So that is probably the biggest thing that's happened to FHIR in the last couple of years, and we are working to make our stuff FHIR enabled so that anybody that supports that standard can just connect to CRISP without doing that much work. It just makes it easier when everybody's talking the same language. It really is the equivalent of everybody in the room speaking the same language instead of different languages. Okay, so I'm going to transition a little bit here. So I talked about FHIR, which stands for Fast Healthcare Interoperability Resources. Essentially the rules of the road for using API data in healthcare. So basically an example would be FHIR only allows you to ask for certain things from a computer system. You can't ask for a million things, you can't ask for just one thing, you have to ask for a certain number of things. It's the rules. There's also a concept of apps, just like on your phone. There's an organization called SMART, which I'm sure stands for something. And SMART apps are essentially another set of rules for building apps. So you might not think about it when you interact on your phone, but all the apps kind of feel the same. Some of the ways you share data, all the menus are the same, and the buttons, the icons are pretty standard. And this helps you work through the different apps on your phone with a common user experience. Well, SMART does the same thing for healthcare apps. It makes sure that the user experience can be mostly the same as you work through a gallery of applications, of healthcare applications you might have. So CRISP actually built a SMART app using the APIs I've talked about, which right now is a blurry screenshot. There's some vendors out there that don't like you to screenshot their stuff, but this is the CRISP app on the right side of a real EMR, where it sort of looks like the portal, right? But you're not going out to the portal. This is inside your EHR. It knows who the patient is, it knows who you are, and it's going and grabbing the information from CRISP. And this is our SMART app, which we have live right now it's live at 5 Epic hospitals. We built a version of this for Cerner. We've talked with eClinicalWorks, we've talked with NextGen. We're working on all of the vendors, not just the hospital vendors, to create a version of this that would allow you to see the CRISP data, again, inside your workflow, but also in a way that CRISP can present it more tailored to who you are. So it could realize the benefits of that maternal health snapshot or that cardiology snapshot, potentially through a CRISP curated view. This is really meant to complement the other stuff I talked about earlier. And this also has some interaction with CRISP. You could submit feedback. There's a glossary of acronyms in here as well. And this has been a focus for the team over the past 6 months or so. We look to continue to build out these types of frameworks, these types of applications into more major EHRs as they're able to support them. Yeah, so I mentioned all of this, but the other cool thing about the app is that it kind of scales, so you can view it full screen, you can view it narrow. It's built in the same web frameworks that mobile phones work, where you can, I don't know if you ever noticed, but you can see a website in mobile view, or you can bring it out to desktop view. So we're using standards when we build these things now. We're not in a world anymore where we have to do proprietary things. Okay, that said, we also have single sign-on. So I mentioned that we are migrating all of the EMRs right now that have a CRISP button. I don't know how many in the room have a CRISP button in their EHR. Okay, good, fair amount. That button now launches the query portal, which are the screen with the 9 boxes and all the information in it. We are in the process now over the next 4 or 5 months of migrating all those buttons to the unified landing page, which I talked about earlier, which is going to give you folks who have access to the button access to other applications like the Snapshot and anything we develop in the future. So there's a tech process going on right now where the IT team is working with the IT folks of your organizations that have the button to move those over. When we do that, that is really going to do a couple things. It's going to get you into our new framework, which is faster. It's going to get you the apps like I mentioned. And it's also going to get you our near match patient service. So later next year, we're going to have the ability for single sign-on users to also see potential close matches. So we've heard a lot from providers who are using that button that they always get taken to one patient. And maybe there's a patient record from LabCorp or Quest that didn't exactly have the same demographics in it, and therefore CRISP created a second patient for it. We're actually going to build a tab inside the unified landing page that lets you say, okay, this is the patient we matched with, but there are these other potential matches. And those of you who use the web version of the ULP are seeing this already. When you do a search, you see the red and green icons are very likely and potential. But we want to make sure we bring that construct to all the users so that you're not just seeing one record. You're seeing other potential records, which we found is actually really powerful in the context of the opioid epidemic. And also a lot of folks who might be in transition period between housing or jobs, getting the near match of the potential other addresses, other phone numbers is going to be important. So that's really the big improvement we're going to make to the process and the single sign-on process next year, outside of moving folks over. And then also getting that button in more EHRs. The more EHRs that have that button, the better. We certainly hear more positive things about that tool that way. Also, federated credentialing. We are working to, this is a little inside, but we're working to basically allow the hospitals and the practices to decide who should have access to CRISP and decide who shouldn't have access to CRISP automatically on their side. So right now, for those of you who might be points of contact with CRISP, there's a really strenuous process of going through the user lists all the time and making sure the right people have access and the people that shouldn't don't. We want to federate as much of that out to your EMR access as possible. So if you have the CRISP button and someone has access to your EHR, they can click their CRISP button. If they leave their job, you take away their EHR access, well, that automatically would eliminate their access to CRISP as well. So there's not a second process of trying to make sure your HR people are contacting CRISP when users are terminated. So we are in the process of testing that now. We have a couple of organizations where we've actually done this already, and it is helpful, especially for the points of contact who are already probably taking in all of the administrative stuff that is thrown on them to meet all the sort of legislative requirements and things that happen day to day in a medical practice. So that's happening as well. Right. That's the point of care. I'm going to jump over to care coordination now. Care coordination is the group where we lump our notification service, which I guess another show of hands, how many folks are using the notification service? Yeah, more of you. This is the service that tends to get the most utilization from CRISP. For those of you who might not be familiar with it, this is us telling you that one of your patients has had an event somewhere in the healthcare ecosystem connected to CRISP. Typically means your patient went to the hospital, we send you an alert. This has probably been live, I want to say this is probably in its 6th or 7th year now. Many of you get a spreadsheet every day at 6 a.m. or 7 a.m. that tells you what happened yesterday. Others of you go into our user interface, which is called Prompt, to see basically the same thing. And then some of you are getting this information pushed directly into your data warehouse or your EHR or your care management program or whatever your ACO, the tool your ACO is using. So there are a number of automated and manual ways in which we can feed you the data. What we haven't been so good about is coming up with automated ways to get the patient lists into CRISP. That is usually the hardest part of this, is uploading a patient panel into CRISP for the patients you want to receive alerts on. So we're doing a couple of things over the next years to improve that process. And we're also doing a couple of things to make it a little easier to filter through the noise. This is turned in, at the beginning, and I remember because I rolled it out to the first site, this was, we thought providers are going to really want to know right away when their patient goes to the hospital. And it turns out most of that is noise. Most of the time, the provider doesn't need to know right away that their patient showed up at the hospital. It's really only for subgroups of patients, especially sick patients. And so we've pivoted to those daily batches and those types of things. But it's really become email these days. It's, you know, how much of your email is worth reading? You know, it's not all of it for sure. It's really, you know, probably, you know, 10% of it or less that throughout the day you really want to be reading. It's even worse with regular mail now. 98% of my regular mail goes right in the recycle bin. So how can we build a tool that highlights for you what's important in the alerts that are coming in, so that you don't have to filter through all the email noise, but by still providing the other alerts for you if you need to see it. So doing a couple of things on that front that are called smart alerts. So that's later in the year. Earlier in the year, and really when I say earlier in the year, I mean in the next 2 months, we're moving the ENS prompt tool, for those of you that use it, into the unified landing page. This eliminates a username and password for you. You'll have one username and password to get to the query portal, to get to Snapshot, to get to PDMP, and to get to prompt, same username and password. That's happening pretty much now. The team's working on that. We are, as I mentioned, improving your ability to load panels. So the self-service panel loader is out in pilot. Some of you may be using it. It means you can load your own panels. You don't need to send them to CRISP. You don't need to wait for CRISP to tell you to send it. You don't need to wait for it to be loaded. You're going to be able to load it yourself. And there's a pretty intuitive user interface for this that will tell you when there are things that are wrong. And of course, our team is always available to talk you through it. We can come sit with you and walk you through it the first few times for sure, knowing this is kind of a paradigm shift. But we want to empower you all to be able to load your own panels. It also will let you kind of subgroup your panels a little bit better on your own side. If there are, you know, 12 patients or 50 patients out of 200 you want to load into certain programs, you can do that through the self-service panel loader. Census View is also coming. So Census View is meant to be less of your patients at the hospital, but more, here are your patients that were recently admitted to the hospital, may still be in the hospital. Here are your patients that were recently discharged from the hospital, and how long ago. So this is more of a traditional census view you might be familiar with in other applications, but essentially, based on the same data, we're making the view a little better for you. So you can, oh, this person was admitted 4 hours ago. Maybe I need to follow up with the care manager at the hospital or the triage person at the hospital. That is also coming in 2019. And then I mentioned smart alerts, which I want to dig into a little bit more detail, and some use cases that are related to that. So I will admit that I don't think CRISP is very good at naming things, and we probably shouldn't be. So you all have better names for things. We're open. We're open to change it. Not a big fan of ULP, not a big fan of smart alerts, but we'll work on that. But I can tell you the smart alerts are pretty cool. Essentially, it allows you to get those notifications built on special rules. So only alert me in a certain circumstance about this patient. Don't alert me all the time. Or in my panel, only alert me the second or third time someone in my panel goes to the hospital over a certain period. Don't alert me all the time. And this is really meant to reduce the noise. So there are a couple examples here, which I'll go through real quick. But basically, let's say I'm discharged from a hospital with a congestive heart failure diagnosis or something like that. I am only going to send an alert to the cardiologist when the discharge has that diagnosis. I'm not going to send the cardiologist a hospital alert for a broken finger because the cardiologist doesn't care about that necessarily. So it allows specialty groups to get more engaged in ENS, and it allows them to triage. You know, they'll probably get some high priority alerts. They'll probably get a few high priority alerts per day now, and not as much noise. So it's really meant to ease your workflow. Another example would be sort of combining information about ED utilization. So the example here really is I'm on your panel. You know, I don't really ever go to the hospital, but all of a sudden I'm going to the hospital a lot. And over the course of a month, when you might have updated your panel next, I could go to the hospital 3 or 4, and in some cases 30 times we've seen. We want to be able to alert you when certain trigger events are hit. So the third time I go to the hospital or second time I go to the hospital in the week, that's when we're going to alert you. We're going to tell you that that's happening. So we're trying to come up with these ideas with you all in the community as well, but give you access to data, sort of the theme you can tell here, is access to the same data, but with a little more intelligence on the top that lets you understand what's important while still giving you access to all of the things related to a patient. And we want to continue to do more of that type of work as healthcare exchange starts to become a little bit commoditized. There's a lot of things moving around. We want to be helpful in helping you all sort through those things. So the last few things I'll say is that I mentioned we use the Agile methodology. What that does, and this is true, this is not a lie, this is true, we are deploying a fix or a feature every 2 weeks to all of our tools. And that is absolutely the case. Now, some of them are really tiny on the back end. You wouldn't necessarily realize it, but some of them are features. And we have, for the major products, long lists of backlogged things we go through every week to prioritize, rank, get scheduled for development, get through. But what we do is totally dictated by you all in the community. There's one that just came in last week where Jeff, who's one of our MedChi outreach folks, was meeting with a provider who said, it's really a pain that you made the date of birth search in the ULP 3 separate boxes, because I used to just copy and paste the date of birth into the ULP, and it saved me so much time. That's the kind of stuff we'll never hear if someone doesn't say it. So it's in the backlog now. We're going to prioritize it, and then that's going to get changed. So all of that kind of feedback is absolutely critical to making this thing work better and in ways you want it to work. So please talk to your CRISP point of contact. Please call the customer care team. Talk to the outreach folks. Grab one of us in the back and tell us what you'd like to see, and we'll work to get it prioritized in the backlog. Like I said, we don't plan more than a year out. We rarely plan more than 6 months out. We like to be flexible. We like to be incremental and pragmatic about what we're doing. So again, please don't hesitate to stop and tell us what you guys want, because we don't know. We don't really know. So that is it. I think I'm maybe a few minutes early here, but thank you all for your time. Again, we'll be here all day, so feel free to stop by and see me if you have any questions or concerns.
Great, thanks everybody, and thank you, Ryan. You know, it's funny, if I could go back in time and tell Ryan that 200 milliseconds is going to be his threshold on response time, he would have laughed at me. We were like, I don't know, 1 or 2 days a couple years ago. And so if you hadn't noticed, kind of the theme this year is use it well. As Ryan said, we're going to be flexible and pragmatic. And so as you come up with use cases, we have the infrastructure that we think can deliver data in meaningful ways, whether it's those API calls or a single sign-on or something we haven't thought of yet, because I'm sure there's a lot of it. And that's really a testament to Ryan, Michael Berger, our CIO, Brandon Neiswender, our COO, and the entire technical operations team who spent all of last year on our theme of It Just Works. We were probably at the conference promising that, you know, things will get loaded faster and bugs will be fixed and we'll be in the cloud. And looking back on it, a lot of things happened to make the current work possible. And it's really great that the team, again, with your input, was able to do that. I also want to highlight real quick, we found last year, and I think we find as we interact with different folks, that CRISP as a proper noun, or even as a verb sometimes, means very different things to different people. You know, when a care manager crisps somebody, they're probably going into the unified landing page, and they're being a detective. They're digging for different work, or different discharge summaries and notes, and they're looking for clues about who that person is and what might be happening with them. When a chief financial officer or someone in rates and reimbursement crisps something, they are looking for minor discrepancies that might change 0.5% in a readmission rate, which affects their reimbursement for the month and the year. And I think that part of the reason I want to highlight this is you're going to see, I think, a slow merging of what it means to crisp somebody over time. In some of the breakouts, you're going to hear about things like patient panels, and the fact that what used to be only used for the encounter notifications, give us your roster of patients, we'll alert you, is now also used for break glass. So when you're in unified landing page, we know that you're searching people you have a treatment relationship with. You have to acknowledge that you don't have a treatment relationship with somebody that you're searching for. And we can audit the pop-ups for break glass. We can also use that same ENS panel to show relationships to other providers. So if I'm in the emergency department and a patient presents, I can see the 4 care management programs already subscribed to that person, and maybe drive some transparency and coordination to the world in that way. So I think you're going to see a lot more of these things coming together, which hopefully means that when I talk to the finance people, when I talk to the care management people, and I talk to the physicians, we'll have a singular understanding of what CRISP means, and it'll probably change a lot over time. Thank you, Ryan, and everybody that made all that possible. Couple notes as we go into a break and then breakouts. So you'll have your the agenda for today. We have 3 sets of breakout sessions. Our intention was to create a lot of different content and then to try and drive themes in the content. And so you'll see kind of 3 different tracks. One that's focused very much on PDMP and the opioid epidemic and the policy and the mandate and getting data for that purpose primarily. You'll see one about care coordination and ENS relationships and care alerts. And then you'll see one about kind of the broader total cost of care model, the Maryland primary care program, and how data is being used in different ways.